Good afternoon, everyone, and thank you for joining us for today's webinar entitled Diagnosis in 16 Years, a Women's Health Public Health Crisis. My name is Janet Choka, and I am HFA's Blood Sisterhood Program Manager. Today's webinar is being presented as a joint effort between HFA's Blood Sisterhood Program and the Foundation for Women and Girls with Blood Disorders. I want to thank you for taking the time out of your day to be with us, and I would like to acknowledge and thank Lauren Nybert, HFA's Programs Director, for helping out and running the technical side of the webinar this afternoon. Before we get started, I just want to go over a few webinar points and helpful hints. We do encourage and welcome your participation and questions in the webinar. However, your audio will be muted by the system for the duration of the webinar, as this just helps eliminate background noise that may disrupt the presentation. If you do have a question, we encourage you to ask it by using the question box at the right bottom of your control panel. We'll hold these questions until the end of the webinar, and then I will pass them along to our speaker to be addressed and answered. To note, today's webinar is being recorded, and we will be posting it to HFA's YouTube channel in the next few days. So please feel free to rewatch it to get more information and share the link with others as well. And finally, we would like to acknowledge CSL Behring and the Centers for Disease Control for their support of HFA and the Blood Sisterhood Program. In today's webinar, you will learn how the Foundation for Women and Girls with Blood Disorders is working to ensure proper diagnosis and optimal management and treatment of women and girls with blood disorders through special initiatives with the 135 federally funded hemophilia, hemostasis, and thrombosis treatment centers across the country. And you'll receive an introduction and overview of the Women and Girls with Blood Disorders Clinics of Excellence Initiative and Directory Project. The directory identifies HTCs that offer services for women and girls and those that have specific women and girls bleeding disorders clinics. Our speaker for this afternoon's webinar is Anne-Marie Nazaro, Executive Director for the Foundation of Women and Girls with Blood Disorders. Anne-Marie Nazaro has more than 25 years' experience in the nonprofit sector, including serving as Executive Director of a regional nonprofit focused on the health of women and senior citizens, and as Vice President for Education at the National Hemophilia Foundation, where she inaugurated and developed the first awareness campaign for von Willebrand disease in women. As a member of the founding staff and board, she began working with the Foundation for Women and Girls with Blood Disorders in 2009. So now I will turn it over to Anne-Marie Nazaro. Thank you, Anne-Marie, for being here for today's presentation.
Thank you so much, Janet, and I want to thank the Hemophilia Federation of America. It's really a pleasure when we get an opportunity, we at FWGBD get an opportunity to speak directly with patients, with the women on this call. So I thank you for joining us today. And I'll say good afternoon for some of us and good morning to those in the Central, Mountain, and Pacific parts of the country. I'd like to take just a few seconds on the title of the webinar this afternoon or this morning. The title is something that I very, very decidedly chose, and it's because having worked in the area of women's health, then hemophilia and women's bleeding disorders and senior health, when I came across that statistic of 16 years waiting that length of time for a diagnosis, I couldn't characterize it any other way than a tragedy, a public health crisis, a women's health crisis. And so that is very important to what we're going to be talking about. It's kind of the raison d'etre, the reason we established a foundation for women and girls with blood disorders. This is the article that gave us that alarming statistic. It was a very neat little study by the CDC back in the early 2000s, published, as you see here, in 2004. And I would suspect that several of you are familiar with this work published by Kertava, but it was interviews that were made possible by the CDC. And they found that the average age at which the first bleeding symptom occurred for the 75 women who had von Willebrand disease already diagnosed, the average age at which they noticed their first symptom or had a bleeding event of concern was 6 years old. The most common symptom as they went along and reviewed their years, these were adult women who were interviewed, adult women with VWD. The most common symptom they reported was heavy menstrual bleeding, known formerly in the literature as menorrhagia and still referred to in that way, but ACOG, the American College of Obstetricians and Gynecologists, has now decided we will refer to it as HMB, heavy menstrual bleeding. 84% of the 75 women reported that that was their most common bleeding symptom. So first seeing that they had a bleed that was concerning at 6 years of age, and then going into menstruation around anywhere from 11 through 13, 14 years of age, nonetheless, these women didn't get a definitive diagnosis that they had von Willebrand disease until 16 years had transpired from their first symptom through their correct diagnosis. To me, that is on the tragic side and worthy of being labeled a crisis. The women I work with, and some very good men as well, the women, though, who started the Foundation for Women and Girls with Blood Disorders really got their sea legs in this area, or their land legs, whatever the expression is, by working in the arena of bleeding disorders. And they were Drs. Andra James, affectionately known as Andy, at Duke University, Dr. Roshni Kulkarni, who was at Michigan State University and was formerly the director of the Blood Disorder Division at the CDC, and Barbara Konkel, who was at University of Pennsylvania, and when we were starting the foundation, she moved over to University of Washington, Seattle. These three women conceived the idea of a foundation labeled what its end goal is, namely to change the lives of women and girls with blood disorders. They wanted a foundation because in their experience, they felt that women and girls with bleeding and other blood disorders were not getting the appropriate attention from providers across the board, from pediatricians through OBGYNs, hematologists, right up to geriatricians. And our three founding women, founding mothers, we sometimes say, since they're all women, and they conceived and birthed the idea of this foundation, they wanted to first begin with the foundation working on educating providers in all those specialties across those disciplines, and working until we can achieve the vision that all women and girls with blood disorders are correctly diagnosed and optimally treated and managed at every single life stage. In today's webinar, I have 4 key objectives. I would like you to come away at the end of this understanding and being able to describe just how FWGBD is working to ensure timely, accurate diagnosis and the best possible management and care for women and girls with blood disorders. I'd like you to be familiar with FWGBD's special initiatives with the 135 federally funded hemophilia, hemostasis, thrombosis centers, HTCs as we refer to them, across the country. And also to be able to describe key elements of our Clinics of Excellence initiative, and to understand and use the FWGBD directory of services and clinics for women and girls with bleeding and other blood disorders within our treatment center system and in other places. This directory, we are hopeful, will be live by May 1 or early part of May. So you'll be getting notification, and you'll see it also through HFA and our website, fwgbd.org, when that directory is live and ready. There are important lessons that we have learned, particularly from adolescent girls. And if you go back to what we said about 16 years till diagnosis, you can understand that we are extremely interested in the adolescents, because if we start to recognize and diagnose and treat properly from early adolescence, then we can begin to cross out that 16 and put in a much, much lower number. So adolescent girls teach us a lot, and we want to work so that they get early diagnosis. Abnormal uterine bleeding is the most common complaint for adolescents when they go to a gynecologist. 40% of these girls report heavy periods. It's also the most common presenting symptom in women with bleeding disorders, but that 40% figure is very high for the adolescents. 10 to 48% by Frischman's study that you see cited at the bottom of the slide, up to 48% of adolescents, young girls coming in with heavy menstrual bleeding, have an underlying bleeding disorder. They are really at the front end. They are the ones we must reach if we're going to do away with that crisis statistic of 16 years till diagnosis. This slide is an opportunity for me to tell you about a young woman I met while working in New York with the Hemophilia Foundation. Helene was actually a physical therapist, and when we met, she was in her late 20s. And she had experienced throughout her middle school years, her high school years, extremely heavy periods, nosebleeds. She was in the physician's office so often that she cut back on her sports, engaging with her sports teams. She gave up her soccer playing, which she really, really loved, and because she was missing so many practices and she was in the doctor's office so frequently. I know this is a familiar story to several of you, but why it is very compelling about Helene, she was a healthcare professional. She was working as a physical therapist. And the luckiest day she had was when she was in her late 20s and she had applied for a position with a New York medical center. And she went to her job, and after a couple of weeks, one of her colleagues said, you know, you seem very tired. You've been calling out already in your short tenure here. Are you okay? Is there anything wrong? And she described her history of, feeling very weak, losing a lot of blood during menstruation, and having other bleeding events. And this colleague happily told Helene that she should make a visit to the hemophilia treatment center that was in that New York medical center. Helene followed up and had a complete workup, telling her she had von Willebrand disease. The important thing about Helene's story is there she was getting diagnosed in her late 20s. When we asked her when she first noticed her symptoms and thought that there was some alarming bleeding events, she said it was 19 years before she got that definitive diagnosis because of her new job as a PT in a big New York medical center that included an HTC. Helene's opportunity to have children was even jeopardized by the level of anemia she was at when she showed up at the HTC. Happily, after a couple of years, she went on to have twin boys. So the right care, the definitive diagnosis, the correct diagnosis, the proper treatment and management saves lives and enriches lives. And I think we know that. The CDC is very interested in these issues. They have made a wonderful video, and I bet some of you have seen this. It's available by going through the Hemophilia Federation of America website. I've given you the specific link, the URL, to get to this video if you'd like to take a look. And I've also given you the cdc.gov website. It's in the National Center for Blood Disorders and Developmental Disabilities portion of the CDC site. And it's interesting to use both resources because in the CDC site, they'll tell you some other free materials that they have for you. And of course, in the Sisterhood site of HFA, you're going to have a wonderful cornucopia of resources that you can use and ways to connect with other women in the Sisterhood. So I recommend both of those sites. And what we learned through CDC, of course, VWD, the most common inherited bleeding disorder, up to 85% of the known bleeding disorders is VWD to date. And it affects 1% of the US population. Most are the mildest form, but many of you might even be labeled this yourself or have been told this is your characterization of VWD. Many in the type 1 are actually type 1 severe. So think about that for a minute, that oxymoron. But it means that there are really bleeding events of significance even in the type 1s and certainly the 2s and 3s. 1 in 5 women with heavy menstrual bleeding are affected by VWD. FWGBD thinks about these issues and tries to look at how can we work on this and how can we get rid of that 16-year wait till diagnosis. And an important thing for us is to change the medical and nursing curriculum and culture. And one thing that one of our board members conducted was a study among 241 OBGYN residency programs. And the findings were very interesting. They reported 9 hours of training that they give to students who are interns in their intern year, 9 hours, 11 hours in the second and third years and fourth years of the interning. And then 67% are reporting that the training in menorrhagia and bleeding disorders is sufficient. If you look at 9 hours in a year and then 11, in a whole year of classes and work and curriculum, that is certainly not what we would call sufficient or appropriate. And furthermore, they learned that less than 25% of these programs reported, of the interns and residents in these programs, less than 25% stated they would send tests for specific bleeding disorders. They would get tests. So they're not really thinking that bleeding, heavy menstrual bleeding, menorrhagia, is an indicator that they need to pay attention to. Even though we've learned through ACOG, ACOG is recommending when you meet an adolescent or a woman with heavy menstrual bleeding, think underlying bleeding disorder. These respondents inconsistently knew the right questions or asked the right questions about bleeding history. And we know from the literature and the experience of Andy, Roshni, Barb Conkle, our medical advisors and other board members, that the right family and personal history are critical to really getting at what is the issue for the woman or the girl that you're seeing. If we think that adolescents are a critical population for lessening the number of years till diagnosis, then we as a foundation need to broker strong relationships and partnerships with key organizations that serve these young women. The FWGBD, it has now done 5 plenary and workshops at the North American Society for Pediatric and Adolescent Gynecology annual meeting. The ACRM means their annual clinic and research meeting. And what has happened over these years, we are starting to see as we continue our work with these young OBGYNs who serve young women and girls, we are seeing that they are now coming to us when we attend these meetings and saying, we were just at the 2016 meeting last month, and we were told by a Canadian OBGYN that she is getting so many more referrals from hematologists who want to work with her, who want to talk about a patient with heavy menstrual bleeding and an underlying bleeding disorder. FWGBD doesn't think you can serve women and girls with bleeding disorders effectively if you don't marry hematology with obstetrics and gynecology. Those are the two key disciplines, medical disciplines, that are necessary to accurately diagnose and to correctly manage and optimally manage and treat these young girls, these young women, and women as they go through the life stages. What I'm showing on the left here is the back of the Journal of Pediatric and Adolescent Gynecology. We've done so well in our partnership that they devoted last April the entire back cover of their journal to our organization. This has also helped us get the testimonial this year again at the plenary and workshop that we did for NASPAG, North American Society of Pediatric Adolescent Gynecology. We were told by a Mississippi OBGYN that she also is getting incredible number of hematology referrals and requests for consults because of the number of young women and girls that they are seeing with menorrhagia and an underlying bleeding disorder, and they want to work in concert with an OBGYN. When we give a workshop or a plenary or a 4-hour symposium at ASH, American Society of Hematology, that we're wont to do, and we've done now 5 years in a row, the ASH Symposia, it's a 4-hour opportunity for training and education. And I display here the first one. This was our inaugural symposium at ASH. And I want to let you know that we're not content just to give education. We'd like to know if it had an effect, if it made an improvement in knowledge on the hematologists or gynecologists who are in the audience. And this is an example of what happened in our very first symposium at ASH in December 2011 when we kicked off our website, our first symposium, and we did a webinar that month as well, our inaugural webinar on women's bleeding disorders. But here are the results. 101 of the attendees, and we had a total of 220 at that symposium. 101 completed their pre and post test, assessing their knowledge before we did the training and after. And out of those, the improvement in knowledge among the 101 who did pre and post test was a 51% improvement in their knowledge about the gynecologic challenges that women and adolescent girls face when they have blood disorders. The mechanism of going to medical society meetings like NASPAG and the ASH meeting, American Society of Hematology, that's the way we get large audiences of target disciplines we need to educate. That's very important to the work we do, and it's kind of the cornerstone. We believe over these years, since 2010 when we launched our logo and 2011 when we started our programs in earnest, we think FWGBD has borne the mark of education of excellence. So we do that in the arena of medical society meetings and nursing meetings. But another mechanism that came about after doing those meetings and getting a reputation, we received a phone call in September of 2013 from the Oregon Health and Science University. Their Hemophilia Treatment Center recognized or saw that they were seeing so many young women and girls with bleeding disorder that they ought to make a designated clinic for these young women. And they were told out there by their colleagues that they ought to call the Foundation for Women and Girls with Blood Disorders because we'd be the organization that could help them make a clinic of excellence for their young women. We've been working with them ever since. Our board, in a board retreat that September, both happened that August, September, our board decided that the Learning Action Network, a mechanism for bringing experienced and wise individuals with people who want to learn about something, you bring them together predominantly on a web platform, and you get them exchanging experience and information and education. So we convened the Learning Action Network for Women and Girls Blood Disorders. And we started back in 2013 with the 7 members that you see here. And by the beginning of this year, 2016, January, we were already up to 37 members. These are individuals, medical directors, hematologists, and OBGYNs who are working out of the hemophilia treatment centers across the country, and one in Canada who's asked to work with us. We had 37 in January, and if Kerry were able to speak on this webinar today, which she is not, she's our Director of Education, Kerry Funkhauser, she would tell you that now we are up to 45 members in the Learning Action Network. This is very good news for women and girls with bleeding disorders and other blood disorders. It means that this is taking on, catching fire with the Hemophilia Treatment Center network across the country and some other centers serving women and girls who want to have services of excellence where you get diagnosed not in 16 years, but in many, many fewer years than that, and where you know you can have confidence in the care you will receive. I want to just show you some of the project milestones for the Learning Action Network. By last spring, a year ago this very month, we were, in fact, it's a year ago today, the 19th, we were able to convene, we wrote a little grant, and we were able to bring our Learning Action Network members, 24 of them, together for an in-person meeting. We chose Baylor University and Texas Children's Hospital in Houston because their Hemophilia Hemostasis Thrombosis Center had a young women's bleeding disorder clinic, WGBD, they initialized it. They had a clinic up and running at that time for more than 5 years. Now they're almost into their 7th year of a designated clinic for young women and girls with bleeding disorders. And they've just added helping women with clotting disorders as well. So it was a natural to say, we will convene our first Learning Action meeting on the ground in a center that can be an in vivo, a live experience of how a center of excellence operates. And that was quite a 2-day meeting for the Learning Action Network members. In that meeting, they were able to hone a model. What should a clinic of excellence for women and girls with bleeding and other blood disorders, what should it include? What is the formula for a model clinic of excellence? And this is what they came up with out of the Houston meeting and other web meetings that we had via the platform that we use for convening on the web. Combined clinical care is at the top of this formula, this set of ingredients. And that refers to what I've been talking about, the marriage of the OBGYN and the hematologist. That's so critical that cross-discipline care is essential. The hemophilia community has set the incredible example for us, for we women. The hemophilia community said to Congress and to their providers, you cannot take care of us if you don't give us cross-discipline, multi-specialty care in one setting. That's how the Hemophilia Treatment Center system came about back in the 70s. That model is non-pareil. It's a model of excellence for others to follow. We're very lucky that having bleeding disorders, we can be part of that treatment center network. But the important thing we have to say to the boys and the men and the providers in that network, if you don't add a critical component of OBGYN or pediatric adolescent gynecology care, you are not giving us the multidisciplinary care, the holistic care that we need as girls and women. So pushing that message is important to FWGBD and to all of us. Combine the clinical care, OBGYN and hematology. The collaborative care team, we still need the other critical members of that HTC team, the PT, the nursing staff, the social worker. They are also critical core elements of a clinic of excellence. The assessment of your patient and your clinical outcomes. It's not enough. Remember how I said we don't just give education, we measure if it's taken. We ask the physicians, are you going to change your practice because of what you learned today? We at least gauge if they have the intention to change practice. In the treatment center and the clinical setting, patients need to express if they're satisfied in getting the holistic and the right and enough care and timely care. And the clinical outcomes, are patients' lives improving? Are women and girls faring better because of what we gave them in that clinic or services of excellence? Those are important things to assess, to know that those outcomes are there. You continue improving and enriching the education that you do, and you have the translational and laboratory research opportunities. If those centers are critical, we want them. I always say, and I have a son with severe hemophilia, kind of at the beginning of my career of working in this, and what turned me into, well, gee, I can apply my training and my graduate and information experience into the area of bleeding disorders. And in the, so why am I saying that he had severe hemophilia? I think I want to say that I learned firsthand through his experience how all of these elements, yes, I agree, he didn't need the gynecologic care, but all those elements were available to him. And he's doing extremely well health-wise with the care that he's been able to receive in the treatment center setting. So we thank the hemophilia community for blazing the trail on comp care. Moving that model into what women need and adding that an element of reproductive health professionals, OBGYNs, pediatric adolescent gynecologists, etc., we are now seeing in the literature that comp clinics are being recognized, clinics of excellence, services of excellence in those treatment center holistic settings are very important. Just this year in hemophilia, one of the two leading journals in hematology, Aisha Zia, who's in our Learning Action Network and moved from Detroit to University of Texas Southwestern, she immediately, when she went to her new university just about a year ago, she went to her division chief and said, you know, we serve young women and girls with bleeding disorders. I would like to start a clinic just for them. And the division chief said, you show me how it's done, you make it work, and then I'll let you keep it. And she did do that. And what she wrote in this journal is an article that describes how she set up her clinic at UT Southwestern. In that same journal article, Barbara Kunkel was asked to review the article and write a commentary about it. And she wrote, women and adolescents with bleeding disorders have unique needs which are not uniformly met by the healthcare system, including specialized bleeding disorder programs. The attention to needs of these girls and development of designated clinics directed to their care, as described in Zia's article, and supported by the Foundation for Women and Girls with Blood Disorders, is an effective and promising way to meet the needs and change, improve the health outcomes for female patients with bleeding disorders. I don't like to read exactly what's on a slide, but that's very important. I would encourage you to take a look at that commentary and Zia's article. Another thing the Learning Action Network is doing while they improve their services at their HTCs, or they strive to set up a clinic of excellence for their young women or adult women with bleeding and other blood disorders, they're also working together in their LAN, in their web platform, and when we meet in person. They're working together to develop treatment algorithms. And this is a little blurry because it's not ready for prime time, but I wanted to reassure you that once these algorithms, the best practice in how you look at treating heavy menstrual bleeding in a woman with an underlying bleeding disorder, these important algorithms will be made available, but when they're refined and ready. The directory project is another outcome of our work with the Learning Action Network. And when we started to see that 7 clinics across the country wanted to work with us, and then 30 and 37 and 45 now, as I mentioned earlier, we said, well, how many clinics designated for women and girls are there across the country in the federally funded HTCs? And we asked CDC and MCHB, and they said, gee, we don't have a list of those that are serving women and girls either in their regular HTC or the ones having a designated clinic. We don't have that in a handy list. So we said at FWGBD, we will interview the 135 HTCs and make a directory of where the clinics are and where the services are and what the complexion of the services are to some degree. So you see here that we found, when we finished 108 of the interviews, we found that of the 108 HTCs we've spoken to already, 25 had designated clinics for either young women or adult women or both. 10 reported to us that they plan to start a designated clinic for either women or girls in the next 18 months after our interview. That's right here. 36 of the HTCs serving women and girls said they also have satellite clinics, remote clinics, where they see additional female patients to the ones who come into their main address at their institution. So that's interesting to know that in some HTCs there's more than one location or opportunity to be seen as a young woman or a woman. 89% told us that the most common condition they're seeing is heavy menstrual bleeding, and 70% offer access to OBGYN care. These are the 25 designated clinics, the HTCs that have a special day or days when only women and girls come together and come in for clinical services. And 4 of them are for adolescent and adult females, 19 just see adolescents, and 2 are doing only adults. That's out of, this was 108 interviews for these data. Of the ones who didn't have a fixed clinic day, they see women and girls in their regular HTC. 24 said they see just adolescent females, 10 said they see adult females, and 49 of the HTCs said both young women and adult women come in. I think we know this is a little bit of an indicator of something we hear in our bleeding disorder community, that we don't transition young people very well into adult care. So some of these adult women were adolescents in the pediatric center, and they remain because nobody's telling them they have to leave till they're after 21, 2, 3, 4, or 5. Here are the conditions most commonly treated in our HTCs that see women and girls, and pretty much our expectation, but it's always nice to have data. And this is from our 108 interviews. So we still have a few more to go to complete the 135, but we will. We will put up on the website in the directory all the interviews that are completed by the time we get to the early May launch date. Here are the top referral sources. If you're a young woman or a woman being seen at a hemophilia treatment center, hemostasis, thrombosis treatment center, how did you get there? Like, who referred you? And we were told by the HTCs, the 108 that we interviewed, and 94 answered this question. Primary care physicians, PCPs, were the top referral sources for young women or women to come. OBGYNs were the second highest source of referrals to HTCs. In the directory project, this is some further information about what the data are telling us. 70%, because we are very interested, remember our marriage of OBGYN care with the hematology care. Just about 70% of 96 who responded to this question, 70% offer access to specialized OBGYN care outside of the HTC. So you can get referred, and they work closely with this OBGYN they refer you to, but you don't see that OBGYN in the HTC or clinic on the same day that you're there for your heme care. 10% offer specialized OBGYN care right within the HTC. 12% have both specialized care inside and can refer you outside. If there's something more monumental and you need to go to an OBGYN outside, they can do both. And 11% are saying they don't have a working relationship with an OBGYN. We can guarantee you, if you're listening in today and if you take this later, we are working to change this number because of what we believe and what we've stated, that OBGYN care married to the hematology care is essential to have true comprehensive care and a clinic of excellence or services of excellence for women and girls with bleeding or other blood disorders. This is just showing you where we've begun to get the word out about our directory and that it's coming. This past month, April, at the Thrombosis Hemostasis Summit of North America, we had a poster accepted where we were able to display and discuss the directory project and that it's coming up. Where are we going next? Well, I'm happy to report that we will be able to have another in-person meeting of the Learning Action Network, and we will again go to a clinic of excellence. This is one that is run by Sarah O'Brien and Farida Hamid at the Ohio State University and Nationwide Children's Hospital in Columbus. And they have also, they're in their 7th year of operating a designated clinic for young women with bleeding and other blood disorders. So we will be meeting in September with the Learning Action Network. We're going to bring up to 30 of our members this time because we're growing and the in-person meeting will grow as well. And we're projecting a meeting for 2017, and we've already been invited to Oregon Health and Science University for that one. We have an invited paper, an invited article in the Journal of Pediatric and Adolescent Gynecology. They have asked us to do an article on clinics of excellence, the core ingredients, and examples of how you get those set up. So we are writing that article now for the Journal of Pediatric and Adolescent Gynecology. And we will be, of course, doing webinars like this, and we're so happy for this opportunity today. So everyone, patients and providers, can understand the work of the Learning Action Network and FWGBD. And we said the online directory, well, we say April because we're hopeful for late April, but it's likely to be the beginning of May for the launch of the directory. And there'll be an online toolkit of how you set up a clinic or services of excellence for women and girls with blood disorders. As a summary of what we've been through here in our time together this afternoon or this morning, depending on where you are in the country, I wanted to just say very briefly some summary points. There will be clinics and services of excellence for women and girls with bleeding and other blood disorders where you need them. That's very much what we are hearing from our interviews for the directory project, from our intensive work with now 45 members from across the country in the WGBD Learning Action Network. This next point, years till diagnosis, this big fat 0 used to say 16. This is where we want to go. This will be no years till diagnosis. You've recognized a critical bleeding symptom, one of the core symptoms. You have a bleeding event of concern, and you get your diagnosis in very close, we hope 0 years or days proximity to recognizing your symptom. And this last one, you put your dream here, because with our work, FWGBD, the Learning Action Network initiatives, with the work of wonderful partner organizations like the Hemophilia Federation of America, and the incredible passion and dedication of you, the patients, the women and girls who endure the repercussions and complications of these disorders every single day, with your help and all of us in concert working together, your dream, whatever it is, going to the moon, whatever you want to accomplish, your dream goes here. Thank you so much for the time that you've given us today. And again, thank you to HFA for this opportunity. And I hope that we've managed to leave some time if anyone has a question or has submitted a question. Thank you.
Thank you, Anne-Marie, for sharing the important work you guys are doing with us today. It's really, really exciting to hear about and really very much needed. So thank you for your time. We do have a few minutes left before the top of the hour. So if there are questions anybody would like to ask Anne-Marie about today's presentation, if you could go ahead and type that into the question box in your control panel, we will try to get to a couple of them. And while we wait a couple minutes for that, for questions to come in, I just want to again take the opportunity to thank CSL Behring and the CDC for their support of HFA and the Blood Sisterhood program. And also just again, a big thank you to Anne-Marie Nazaro for sharing about the great work that the Foundation is doing for women and girls with bleeding disorders. And to thank all of you for taking the time to log in and be with us today. So let me look and see here if there are any questions that have come in. Looks like there is one here. What other types of information are you learning about women from your conversations with the HTCs for the directory?
That's a very good question. Thank you. So importantly, I think what really what really hit us when we had these conversations, and most of them were live interviews, phone interviews. Some chose to answer the questions online, but the majority of the 108 to date have done a live phone interview with us. And what I was struck by, and of course, you know, the interviewer always understands that people like to be nice and tell you sometimes what you want to hear. But I have to say, I was struck by the sincerity and the passion that many, many, many of the interviewees had about working in this area, their work in this area, and wanting to make improvement in this area. I think we mentioned in one of the slides that more treatment centers than the 25 who have a designated clinic want to create a clinic. So that was very telling for us that they want to do this. One thing that we learned is that the HTCs, even with good intentions to marry the services of their hematologists, be it their pediatric hematologist, their adult hematologist, with OBGYN, they are encountering some hurdles getting that relationship. And sometimes, and this was so important, we have so many notes on these interviews, sometimes the hurdle is a logistical hurdle. They might have identified the pediatric gynecologist who wants to work with them, or the OBGYN who wants to be connected to the treatment center to see these young women or these girls or women. However, the mechanics are difficult, so they need to overcome the hurdle of, gee, that's two specialties, that's two different departments at our institution. How do we use two different kinds of services. How do we do the billing? What are the mechanics of making that marriage work? So think about the Learning Action Network. We have with us now the Sarah O'Briens, the Jen Dietrich and Lakshmi Srivats at Baylor and Texas Children's. We have clinics that have been established for more than 5 years. They're working in the Learning Action Network. We go to them and say, well, you overcame this hurdle. How can we help others to work out the mechanics? So that was one very important finding. Even if you identify the OBGYN, you might have a mechanical or logistical hurdle, and FWGBD is there to help you overcome that. That's the kind of information. I mean, that doesn't show in the directory that we're working in the background to get these things straightened out and accomplished, so OBGYN care can be there for you when you show up at your HTC. But that came out of the interviews, and that's very helpful for us. Does that help answer the question, Janet?
Yes, I think that was a great answer. Thank you. There was one more that came in, and it is, how do you go about educating providers about